This is Colleen Parsons, and this is Lecture 5 on Skin, Hair, and Nails. I'm going to go through this as quickly as I can, trying to keep to our under 20-minute time limit. So many of these slides I'm just going to skip through. You have access to this entire PowerPoint, so you can go through it at your leisure, but it's all in Chapter 12 of your textbook. Make sure you do review your anatomy of the skin. And just to briefly look at it, our skin does tell quite a story, and it can reveal much about your patient without them even opening their mouth and saying a single word. So what does your patient's skin reveal to you, the nurse? About the patient's environment, their lifestyle, their health status, and their nutritional status, as well as their self-care. Think about that for a second. Look at the people, maybe not around you in this classroom, but the people you know outside of the college environment. And it may or may not tell you much about their environment or their occupation. For instance, somebody who works hard on machinery is going to have oil, grease embedded into their skin. People who work hard with the dirt are going to have that imprinted on their skin, on their face. The skin, as you know, is our largest organ, and it's designed to protect all of the rest of our organs and systems. Our nail beds are there and they are considered part of the skin. So understand that when you are doing an evaluation, an assessment of people's nails. It's waterproof, it's protective, and it's adaptive. It also produces vitamin D, and we get that from the sun. So there's a big debate right now whether going outside without sunscreen on, of course you can't be out there to burn your skin, but some of the research is saying you should be outside for a period of time, and I recommend at least 15 minutes a day without any sunscreen on at all, so that you can soak in that vitamin D. People in the northern climates have an incredibly low predisposition for vitamin D. You know that this icky stuff is vernix that covers the baby's skin. It's waxy, and while they're in utero, while they're swimming around in the amniotic fluid, this waxy stuff protects them. There are some things that occur with pregnancy, striaea, this mask of pregnancy, these lines of Niagara, I'm going to say it wrong here, but that go down through the middle of the abdomen while a woman is pregnant. These things have a tendency to lighten up, so after birth. As we age, our skin gets more fragile, and becomes more transparent, as you can see here, especially in Caucasian skin. Culture and genetics, we've covered this before, and there's quite a bit probably in your book, but the idea here is that different lifestyles and different genetics predispose us to common types of cancer, skin cancer. So this is basal cell carcinoma. This is more of a precancerous condition. This is squamous cell carcinoma, and this is the beginnings of melanoma. Here are some of your subjective data, health history questions in there in your book. As you can see here, we're not talking about just the skin, the things that you think of as skin, but we're also talking about the nails, because that is part of our skin. Health history questions for infants and children are a little bit different. We ask about birthmarks because those things can be important. anything that the children are born with, there might be a predisposition towards an illness or a an impact on a child's health because of what we see as a birthmark. I'm not going to go into this now, but if you have a specific question, please feel free to ask. Adolescents have a tendency to be very worried about their skin, especially when it comes to pimples and blackheads. And aging adults have a predisposition to a delayed wound healing and significant problems with their feet, such as bunions. The shape of their foot changes. How are they wearing their shoes? How are their toenails? They can't bend over to very easily to trim their own toenails, and toenails get to be really hard and thick, especially men's toenails, so that may contribute to problems. When we're looking at the skin, we're also asking about bruises and trauma. Looking for those things. What kind of trauma has occurred here? Has it been light trauma, just accidental? And what does that mean? Is the patient on a blood thinner? That will make a difference. And a history of diabetes or peripheral vascular disease will play a part in your skin assessment. We are, well, this is just preparing. We won't be using a Woods light or a magnifying glass. But if you go to a dermatologist's office, you will very often see that they have a Woods light and magnifying glass as part of what's your physical examination. So our complete physical examination is looking at the skin, but we don't look at it when we look at the complete skin, all of the skin of our patients. And we don't just look at it per se, we are looking at it in combination with other things. So we are examining the skin in its entirety while we are examining the rest of the body. So you are doing you'll learn as you go through your health assessment course, you are often doing 2, 3, 4 things simultaneously. So for our purposes today, you don't really just look at the skin. As we talked about before, when you shake somebody's hands, you're getting information about the skin. When you are doing your skin assessment, that becomes part of the rest of your complete physical assessment. And don't forget to look between the fingers and toes, because that will tell you things that sometimes you don't want to know. So I'm just going to skip through some of the slides of pictures so you can go through that either in your book or later in these slides. But we're also feeling for temperature. We're looking at colors. We're looking at moles. We're looking at moisture, texture, thickness, edema, so many things when we're looking at the skin. But we want to especially talk about lesions, which are any wound, any abnormality on the skin is considered a lesion. There are many ways to express or identify lesions, and those are all at the end of this presentation. You're looking at the color. Is it elevated? Does it dip under the skin? What is the pattern or shape of it? What is the size? If it is a boo-boo, like this one, an open wound, you really want to measure those so that you can tell if they're healing and getting better, or if they're not healing and getting worse or remaining the same. Exudate is pussiness or anything that oozes from a wound. You want to note the color and odor. You want to notice if there is a lesion, if it's warmer around, if there's a temperature change around the lesion. Very often it will be a little bit warmer as it's healing than in areas more distal from the lesion. Then when we talk, hair is also part of skin for the purposes of this, and hair color, texture, distribution, and lesions on the scalp are parts of our assessment for that. There are some, excuse me, there are some diagnoses that the symptoms will come out in the quality and texture of one's hair. An easy one that comes to mind is a thyroid condition, and then there are some other genetic malformations or difficulties, such as inability to process copper, and you get a very weird hair with that. Whoops, backwards. So again, nails. Capillary refill is something that you'll be doing all of the time, where you're actually pressing on the fingernail and releasing and seeing how fast the nail returns to pink. You want the nail to return to pink in 1 or 2 seconds. 2 seconds is kind of long. You're really looking for that 1001 and seeing that it's coming back quickly. Self-breast examination is important, and that is part of your skin, the outside of the breast. But here we're talking about skin assessment, so you're asking your patients to really look at their skin all over and using a mirror. It can be hard for them, but if they have a partner, they can have somebody else look, including the soles of their feet. Things like decubiti occur on the soles of the feet, and some melanomas have been discovered on the soles of the feet. Back of the neck, scalp, those are all really important places that we don't often look at. You can review your infant skin presentations. This is somewhat covered in more depth in your pediatric course. So you have your adolescent skin issues, and that causes a lot of problems for some adolescents and no problems for others. Pregnancy and aging. Of course, all of us who are aging have all kinds of weird things that happen to our skin and hair and nails. So here's a summary of your checklist of things that you're looking for. And we really want to teach our patients that self-examination, and anything that they're concerned about at all, they should come to their physician or their provider. So here's a list of some of the shapes and configurations of lesions. You do want to know these. You really do. You want to know these at some point in your career, because you will sound much more professional if you know what people are talking about. And I'm just flipping through these so that you can return to them at your leisure, because you want to learn this information. And when you see a grouping of lesions, you want to be able to describe that they're grouped, that they're raised, that they're polycyclic, this one is linear, and primary skin lesions. Here they all are for you to see. Secondary skin lesions are lesions just on the surface of the skin. And this is how you would describe them. It's inside an ear if you can't make out what that is. Vascular lesions. So that also may include trauma. Here's how a bruise would, day 1 to day 5 of a bruise. And there is a whole list of other lesions in children. that you want to look into, because people are not always getting their children vaccinated, and you will see these. Diaper dermatitis is one that you'll see often if you work with children, but all of and impetigo, candida, eczema you'll see readily. I wish you didn't see rubeola or rubella or varicella, but you will, and they're important to note. All right, thank you very much. Have a good day.